The next lecture will focus on fractures. First, we'll talk about musculoskeletal injuries, which include soft tissue injuries. Strains are a stretching of the muscle and fascia. Sprains are wrenching, twisting with injury to the tendons and ligament structure. Dislocations are severe injury to the ligamentous structure. And it's a complete displacement or separation of the articular surfaces of a joint. And then subluxation is partial or incomplete displacement of the joint. Fractures are a disruption or break in the continuity of the structure of the bone. Most fractures happen because of trauma, but some are caused by the disease process, such as cancer or osteoporosis. Fractures are described and classified according to their type, whether there's communication or non-communication with the external environment, and the anatomic location of the fracture on the involved bone. These are the different types of fractures to give you a picture of what they mean. Most are self-explanatory. Avulsion is when there are fragments that rip away from the main bone structure itself, and comminuted is basically when there are many pieces or it's shattered. Fractures can also be classified as closed or open. An open fracture is a compound fracture with communication of the bone through the skin. It can be from inside or outside. So from inside, the bone sticks through the skin, and from outside, this stab wound demonstrates how the bone would be punctured and fractured. And then a closed fracture is inside the skin. Classifications are also done according to the location on the bone. So with this tibia, you can see that in the proximal third of the bone, there's a tibial plateau and the tibial tuberosity, both of which can be fractured. The middle third is where the tibial shaft would be, and the lateral malleolus is the distal third. Fractures can also be described as stable or unstable. A stable fracture, there's still a piece of the periosteum intact across the fracture. And with this, either internal or external fixation can render the fragment stationary. Other stable fractures include transverse, spiral, and green stick fractures. Unstable fractures are grossly displaced during the injury, or there's a poor fixation, and usually these are comminuted or oblique. The clinical manifestations include the following signs and symptoms. There's immediate localized pain, decrease in function, inability to bear weight on or use the affected part, and the patient guards and protects that extremity. The fracture may not be accompanied by obvious bone deformity. Immobilization of the extremity is important if a fracture is suspected, and any unnecessary motion increases the soft tissue damage and might convert a closed fracture to an open fracture. There are 6 stages of fracture healing. First, there's a hematoma that's created around the fracture. Then the site granulates, and there's granulation of the tissue. A callus forms. Then bone starts to be built in the ossification stage. Consolidation occurs, and then there's remodeling. This slide depicts the stages of bone healing. A shows the hematoma formation because of bleeding at the ends of the fractured bone. The second picture is the organization of the hematoma into a fibrous network. C is the invasion of the osteoblasts, lengthening of the collagen strands, and deposition of calcium. In D, there's a callus formation where new bone is built up as osteoclasts destroy the dead bone. And then in E, there's remodeling as excess callus is reabsorbed and trabecular bone is laid down. In the initial stages of the injury, the first 72 hours is when the hematoma occurs. And it's the extravasated blood that changes from a liquid to a semi-solid clot. 3 to 4 days after the injury is the granulation of the tissue, where new blood vessels, fibroblasts, and osteoblasts are formed. The callus formation occurs by the end of the second week, and this can be verified by X-ray. And minerals and new bone matrix are deposited in the osteoid, and an organized network of bone is formed in that's woven around the fracture parts. It's mainly composed of cartilage, osteoblasts, calcium, and phosphorus. Consolidation is the radiologic union, where X-ray provides evidence of complete bony union, and this phase can take up to a year after the injury. Remodeling also takes quite a while. Initially, the stress needs to be provided through exercise. Weight bearing is gradually introduced, and the new bone is deposited in sites that are subjected to stress and reabsorbed at areas where there's little stress. So any excess bone tissue is reabsorbed during remodeling, union is completed, and radiologic union is present. Factors that influence healing are age, the immobilization of the limb, hormones that might be present, where it's located, the initial displacement, any implants, infection, and the blood supply to the area. Fracture healing may not occur in the expected amount of time or may not occur at all, and healing time of fractures increases with age. An example of the influence of age is an uncomplicated midshaft fracture of the femur. Heals in 3 weeks in a newborn, but it takes 20 weeks in the adult. And the ossification process may be arrested by inadequate reduction and immobilization, by excessive movement or infection, poor nutrition, or other systemic disease. And there is a table that summarizes the complications of fracture healing. It would be table 63.5. Electrical stimulation and pulsed electromagnetic fields are used to help stimulate bone healing. The underlying mechanism for electrically induced bone remodeling is unknown, and it's thought to be related to negative electric fields attracting positive ions such as calcium. The overall goals of fracture treatment are anatomical realignment of bone fragments, immobilization to maintain realignment, and restoration of normal or near normal function of injured parts. Table 63.6 summarizes the collaborative care of fractures. The reduction of the fractures is done in 2 different ways. Closed reduction is the non-surgical manual realignment of bone fragments to previous anatomic positions. That's usually performed while the patient has general or local anesthesia depending on the situation. And then after reduction, traction, casting, external fixation, Splints or other orthotic devices like braces would immobilize the injured part to maintain alignment until healing occurs. Open reduction is correction of the bone alignment using a surgical incision, and the addition of internal fixation, which uses screws or wires, pins, intermedullary rods, plates, or nails. The type and location of fracture, the age of the patient, the presence of concurrent disease, and whether they've already tried to do a closed reduction influences the decision to whether to use open reduction. The chief disadvantages of open reduction are the potential for infection, complications with anesthesia, and the effects of other premorbid medical conditions. If the open reduction with internal fixation is used for interarticular joints, there can be early initiation of range of motion, and CPM, or continuous passive motion machine, is used to prevent adhesions and allows faster reconstruction with fewer complications. Traction is the application of a pulling force to an injured or diseased body part or extremity, while countertraction pulls in the opposite direction. So the purpose of any traction is to prevent or decrease muscle spasm, immobilize the joint or body part, decrease the fracture or dislocation, and treat the pathologic joint condition. Traction is also indicated to provide immobilization to prevent soft tissue damage, to reduce muscle spasm associated with low back pain or cervical whiplash, and to expand the joint space during arthroscopic procedures or before a major joint reconstruction. The two most common types of traction are skin traction and skeletal traction. Skin traction is used for short-term treatment until the skeletal traction or surgery is possible. It includes tape, boots, or splints that are applied directly to the skin to maintain alignment, assist in reduction, and help diminish muscle spasms in an injured extremity. Usually the traction weight is 5 or 10 pounds. It's generally used for 48 to 72 hours, and pelvic or cervical skin traction may require heavier weights applied intermittently. Skeletal traction, on the other hand, is in place for longer periods. It's used to align injured bones and joints or to treat joint contractures and congenital hip dysplasia. It provides a long-term pull that keeps the injured bones and joints aligned. The physician inserts pins or wires into the bone, either partially or completely, and aligns and immobilizes the injured body part. The skeletal traction weight is between 5 and 45 pounds, but too much weight can result in delayed union or non-union. The major disadvantages of skeletal traction are infection in the area where the pin is inserted and the consequences of prolonged immobility. When traction is used, forces are usually exerted on the distal fragment to obtain alignment with the proximal fragment, and Buck's traction is an example of that, and this is a picture of Buck's traction. You can see that the weight is pulling on the distal part of the fracture, and the plan is to realign the distal portion with the proximal portion. Fracture alignment depends on correct positioning and alignment while the traction forces remain constant, and the forces must be pulling in the opposite direction to prevent the patient from sliding to the end or the side of the bed. Countertraction is commonly supplied by the patient's body weight, or it's augmented by elevating the end of the bed. And it's very important that the nurse maintains the traction constantly and doesn't interrupt the weight that's applied to the traction. Casts are a temporary immobilization device that goes all the way around the extremity. It allows the patients to do many more activities of daily living than traction does. And cast materials are natural, synthetic, acrylic, fiberglass-free, latex-free, polymers, or a hybrid of all of those. And they are commonly used as treatment after a closed reduction. The application incorporates the joint above and below the fracture most often, and it restricts the tendinoligamentous movement, so it assists with joint stabilization while the fracture heals. So after they immerse it in water, a plaster of Paris is wrapped around and molded around the affected part after the bony prominences have been padded. There's a number of layers and techniques that determine the strength of the cast. After the cast is dry, it's strong and firm and can withstand stressors, and it sets in about 15 minutes, but is not strong enough for weight bearing until 24 to 72 hours after application. Fresh plaster shouldn't be covered. During the drying period, the cast should be kept clean and dry, and direct pressure should be avoided. And though once it's dry, the edges need to be pedaled, which helps to make sure there's no skin irritation. And you should handle the cast gently with an open palm to avoid denting. And this is a depiction of pedaling. Synthetic casting materials are molded to fit the torso or extremity after being activated by submersion in cool or tepid water. They're used more often because it's lightweight and relatively waterproof and provides immediate immobilization. Different types of casts include sugar tong splint, posterior splint, short arm cast, and long arm cast. You can see from this picture the different types of casting. A sugar tong splint is used often with acute wrist injuries and injuries that result in significant swelling. And then a posterior splint will accommodate swelling in a fractured extremity after the injury. Plaster splints are applied over a well-padded forearm, beginning with the phalangeal joints of the hand and extending up the dorsal aspect of the forearm around the distal humerus, and then extending down the volar aspect of the forearm to the distal palmar crease. A short arm cast is treatment of a stable wrist or metacarpal fracture, and it's a circular cast that extends from the distal palmar area to the proximal forearm. It provides wrist immobilization and permits unrestricted elbow motion. A long arm cast is treatment for stable forearm or elbow fractures and unstable wrist fractures. It is similar to a short arm cast but extends to the proximal humerus, and it restricts motion in the wrist and elbow. The nurse should direct care in supporting the extremity and reducing the effects of edema by maintaining extremity elevation with a sling. When a hanging arm cast is used for a proximal humerus fracture, the elevation or a supportive sling is contraindicated because hanging provides traction and maintains fracture alignment. The sling will support the extremity and reduce edema by maintaining elevation. It is contraindicated for proximal humerus fractures. You want to ensure that the axillary area is well padded to prevent skin excoriation and maceration. Placement should not put undue pressure on the posterior neck, and the patient should be encouraged to move their fingers and the non-immobilized joints of the upper extremity. A body jacket or brace is used to immobilize and support stable spinal injuries of the thoracic or lumbar spine. The cast is applied around the chest and abdomen and extends from above the nipple line to the pubis. After application, the nurse should assess the patient for cast syndrome, which happens if the cast is applied too tightly. With cast syndrome, the patient will generally complain of abdominal pain, abdominal pressure, nausea, or vomiting. And treatment includes gastric decompression with a nasogastric tube and suction. And the cast may need to be split or removed. And there you are. And it is a compression of the superior mesenteric artery against the duodenum. The nursing assessment also includes observation of respiratory status, bowel and bladder function, and the areas of pressure around bony prominences. During the time that's required for the cast to dry, the patient should be repositioned every 2 or 3 hours. A hip spica cast is used for femoral fractures to immobilize the affected extremity and the trunk securely, and it includes 2 casts joined together, a body jacket cast and a long leg cast. The location of the femoral fracture will determine whether the thigh of the unaffected extremity will have to be immobilized to restrict the rotation of the pelvis and the possible hip motion on the side of the femoral fracture. A hip spica cast extends from above the nipple line to the base of the foot, is a single spica, and may include the opposite extremity up to an area above the knee, or both extremities. So it would be a spica and a half, or if it's both extremities, it's a double spica. You would assess the patient for the same problems as you would with a body jacket cast. The nurse should instruct the patient in positioning activities required to get on and off the bedpan, and a fracture bedpan may be used. When the patient is positioned, the support bar joining the thighs must never be used to assist in moving because the bar can break and cause cast disruption. Injuries to the lower extremities are often immobilized by either a long leg cast, a short leg cast, a cylinder cast, a Jones dressing, or a prefabricated splint or immobilizer. A short leg cast can be used for a variety of conditions, but is mainly used for stable ankle and foot injuries. A cylinder cast is used for knee injuries or fractures. A Jones dressing is composed of bulky padding materials, splints, and an elastic wrap or bias cut stockinette. The usual indications for a long leg cast include an unstable ankle fracture, soft tissue injuries, fractured tibia, and knee injuries. The cast usually extends from the base of the toes to the groin and the gluteal crease. You should elevate the extremity on pillows to above the heart level for the first 24 hours. After the initial phase, the casted extremity should not be placed in a dependent position because of the possibility of excessive edema and not enough room inside the cast. And you should observe for signs of pressure. This is a knee immobilizer. Prefabricated knee and ankle splints and immobilizers are being used in many settings. This type of immobilization, which allows close observation of the affected joint for signs of swelling and skin breakdown, is easy to apply and remove. External fixation is a metallic device composed of metal pins inserted into the bone and attached to external rods. It applies traction or compresses fracture fragments, and it immobilizes the lower fragments when a cast or other traction is not appropriate. And it closely resembles an erector set. The external device holds the fracture fragments in place, similar to a surgically implanted internal device, and it attaches directly to the bone by percutaneous transfixing pins or wires. This is an external fixator device that's stabilizing a hand injury, and the other demonstrates tibial external fixation. Looks like an erector set. External fixation is indicated in simple fractures as well as complex fractures with extensive soft tissue damage. It's used in the correction of bony defects that are congenital, pseudoarthrosis, non-union or malunion, and limb lengthening. External fixation has many advantages over other fracture management strategies and is often employed in an attempt to salvage an extremity that might otherwise require amputation. Infection control is critical with external fixation. Infection would be signaled by exudate, erythema, tenderness, and pain, and the patient and family should be instructed on meticulous skin care. Although every physician has their own protocol for pin care and cleaning, half-strength hydrogen peroxide with normal saline is often the choice. An internal fixator is surgically inserted at the time of the realignment. It's a biologically inert metal device that uses titanium, vitillainium, or stainless steel, and the evaluation of the alignment is done by Patients have different degrees of pain associated with muscle spasms. Involuntary reflexes result from edema and nerve injury after a muscle injury. And quite often central and peripheral muscle relaxants are prescribed. They would include carisoprodol, which is Soma, cyclobenzaprine, which is Flexeril, or methcarbamol, which is Robaxin. Side effects that are associated with muscle relaxant include drowsiness, lassitude, headache, weakness and fatigue, blurred vision, ataxia, and GI upset. Hypersensitivity reactions may include skin rash or itchiness. Ingestion of large doses of muscle relaxants may cause hypotension, tachycardia, or respiratory depression. And the potential habituating effects associated with long-term use and potential for abuse really need to be considered. Proper nutrition is very important. Adequate energy sources are needed to promote muscle strength and tone, build endurance, and provide energy for ambulation and gait training exercises. The patient's dietary requirements must include at least 1 gram per kilogram of body weight of protein, vitamins B, C, and D, calcium, phosphorus, and magnesium. Low serum protein levels and vitamin C deficiencies interfere with tissue healing, and immobility and callus formation need calcium. Adequate fluid intake is 2,000 to 3,000 milliliters a day with a high fiber diet, including fruits and vegetables. If a patient's in a body jacket or a hip spica cast, use 6 small meals a day. Otherwise, 3 well-balanced meals a day usually provide adequate nutrition. The nursing assessment findings would be a deformity or unnatural position of the affected limb, edema and bruising, muscle spasms, tenderness and pain, and loss of function. The subjective and objective data that should be obtained from an individual with a fracture is presented in Table 63.8. Other findings include numbness and tingling and loss of distal pulses, grating or crepitus, an open wound over the injured site with exposure of bone, and initial treatment is still life-threatening injuries first, which includes ensuring airway breathing and circulation, then controlling external bleeding with direct pressure or sterile pressure dressings and elevation of the extremity. And you should splint joints above and below the fracture sites. Other initial treatment includes checking neurovascular status distal to the injury before and after splinting to make sure you don't pinch off a blood vessel. Elevate the injured limb if possible. Don't try to straighten the fracture or dislocated joint, and don't manipulate the protruding bone ends. Apply ice to the affected area and obtain x-rays. Give the patient tetanus diphtheria prophylaxis, and that would also include pertussis these days. Mark the location of pulses so that in repeat assessment it's easy to find them, and splint the fracture site. For ongoing monitoring, you're going to monitor vital signs, level of consciousness, oxygen saturation, neurovascular status, and pain. You're going to watch for compartment syndrome, which would be characterized by excessive pain, pallor, paresthesia, paralysis, and pulselessness. And you're going to monitor for fat embolism. Subjective data that you should obtain is past health history of traumatic injury, long-term repetitive forces such as stress fractures, bone or systemic disease, prolonged immobility, osteopenia, or osteoporosis. You want to find out if the patient is on medications, specifically steroids and analgesics, because it'll be more difficult to treat their pain if they're already taking analgesics. For surgery and other treatment, you want to determine what was done for first aid treatment of the fracture and what previous musculoskeletal injuries did the patient have. For health perception, talk to the patient about health management. Are they on estrogen replacement therapy or calcium supplements? What kind of activity or exercise do they do? And do they have muscle spasms? Under cognitive and perceptual, you want to determine if the patient had sudden and severe pain in the affected areas, if there's any numbness, tingling, or loss of sensation, and any chronic pain that increases with activity. Objectively, you're observing for apprehension or guarding of the injury, skin lacerations, pallor and cool skin or bluish and warm distal to the injury, looking for ecchymosis, hematoma, and edema at the site of the fracture. You're also monitoring for decreased or absent pulses distal to the injury, decreased skin temperature, delayed capillary refill, paresthesias, decreased or absent sensation, or hypersensation. Try to determine if there is restricted or loss of function of the affected body part. Are there any local bone deformities, abnormal angulation, shortening, rotation, or crepitation of the affected part, or any muscle weakness? You want to determine the localization and extent of the fractures by doing x-rays or bone scans or CT or MRI. The neurovascular assessment, be aware that musculoskeletal injuries can cause changes in neurovascular status. It can cause nerve or vascular damage, either with application of a cast or constrictive dressing, poor positioning, or in physiologic response. Neurovascular assessment should consist of a peripheral vascular assessment, which includes color, temperature, capillary refill, peripheral pulses, and presence of edema. And a peripheral neurologic assessment would include sensation, motor function, and pain. Nursing diagnoses would include impaired physical mobility, risk for peripheral neurovascular dysfunction, acute pain, and ineffective therapeutic regimen management. Your overall goals should be to have physiologic healing with no associated complications. You want to obtain satisfactory pain relief, and you want to achieve maximal rehab potential. The health promotion aspects would be that the public should be taught to take appropriate safety precautions to avoid fracture. Personal actions known to reduce injury include regular use of seat belts, driving within the posted speed limits, warming up muscles before exercise, use of protective athletic equipment like helmets and knee, wrist, and elbow pads, use of safety equipment at work, and not combining drinking and driving. For acute intervention, patients with fractures can be treated in the ER or in a physician's office. Patients are generally released home, or they can require hospitalization. The specific nursing measures you would take depend on the type of treatment you would use and the setting where the patient is. If the patient's going to surgery preoperatively, the nurse should tell the patient of any immobilization or assistive devices that will be used and what expected activity limits there will be after surgery. You want to assure the patients that their needs will be met and that they'll have adequate pain medication available. Also, skin preparation is very important, so you want to help the patient cleanse the skin to remove debris and hair to reduce infection. There's a different protocol. It varies by institutions. And understand that hair removal is often clipping, not shaving. Postoperatively, you're going to monitor vital signs and apply general principles of nursing care for postoperative patients. You'll perform frequent neuromuscular assessments of the affected extremity and minimize pain and discomfort through proper alignment and positioning. You'll monitor limitations in movement, carefully observe dressings or casts for bleeding or drainage. Any significant increase in the size of the drainage areas should be reported, and you should measure and assess the patency of the system and any volume if there's drainage. Constipation is often a consequence of pain medication and immobility, so you want to prevent that by increasing activity if possible. High fluid intakes of greater than 2,500 milliliters a day. A diet high in bulk and roughage. Warm fluids, stool softeners, laxatives, or suppositories may be necessary. And it's always a good idea to keep a regular time for elimination to promote regularity. Patients may develop renal calculi because of bone demineralization. You should therefore encourage fluid intake and the use of cranberry juice or ascorbic acid. Rapid deconditioning of the cardiopulmonary system occurs in these patients because of prolonged bed rest and results in orthostatic hypotension and decreased lung capacity. So unless it's otherwise contraindicated, you want to diminish these effects by having the patient sit up in bed, uh, have them dangle over the side of the bed, or have them perform standing transfers, and make sure that if you, as you increase activity, you're assessing for orthostatic hypotension. Other problems with the cardiopulmonary system that must be assessed in addition to orthostatic hypotension include venous thrombosis and pulmonary emboli. If the patient is in traction, you should inspect exposed skin regularly where slings are used with traction, and decrease the pressure over bony prominences that might be created by wrinkled sheets or bedclothes because they can cause pressure necrosis. Persistent skin pressure may impair blood flow and cause injury to peripheral neurovascular structures, so be careful of that. Observe skeletal traction pins for infection, and care of the pin sites varies, but usually includes regular removal of any exudate and rinsing of the pin sites and drying of the area. External rotation of the hip can occur when skin traction is used on lower extremities, so be aware of that. You can correct this position by putting a pillow, a sandbag, or a rolled up draw sheet along the greater trochanteric region of the femur. Generally, the patient should be in the center of the bed in a supine position. Incorrect alignment can result in increased pain and malunion or non-union. To offset some of these problems associated with prolonged immobility, discuss the specific patient activities with the healthcare provider, and if exercise is permitted, encourage participation by the patient in a simple exercise regimen based on activity restrictions. Cast care, if the patient does have a cast, you should be applying ice directly over the fracture site for the first 24 hours. But before you do that, check with the healthcare provider to make sure that you don't get fiberglass wet. Once the cast is exposed to water, it should be dried, and elevate the extremity above the heart for the first 48 hours. Also, you want to move joints regularly that are above and below the cast. Report signs of possible problems to the healthcare provider, and make sure that the patient understands the importance of keeping the appointment to have the fracture itself and the cast checked. Things to avoid include don't get a plaster cast wet. Instruct the patient not to remove any of the padding or insert objects inside the cast. Sometimes it gets itchy and they stick things in there. But they're there for the duration, and it makes the cast tight and can cause pressure sores. They should not bear weight on a new cast for 48 hours, and not all casts should have weight borne anyway. And cover the cast with plastic for, they should not cover the cast with plastic for prolonged periods. Short-term rehab goals would include transitioning from dependence to independence in performing simple ADLs, and preservation or increase in strength and endurance. Long-term rehab goals would include prevention of problems associated with musculoskeletal injuries. The table 6310 has more information on that topic. Reinforce any physical therapy instructions that may have been given, and you may need to assist the patient with lower extremity dysfunction to start mobility training. And usually it's once they're able to sit up in bed, they'll dangle their feet over the side. Mobility training and instruction is the use of assistive aids like canes, crutches, and walkers, and that constitutes a major area of responsibility for the physical therapist. So they'll be doing some education with the patient as well, if they're available. Degrees of weight-bearing ambulation include non-weight-bearing, touchdown, toe touchdown, partial weight, weight-bearing, and full weight-bearing. Various assistive devices are available, cane or walker or crutches. It's the healthcare provider that makes the decision about which device should be used, and it really involves the balancing the need of maximum stability and safety. Common gait patterns with assistive devices are 2-point gait, 4-point gait, swing to gait, and swing through gait. A transfer belt should be put around the patient's waist to provide stability during the learning stages and discourage patients from reaching for furniture or relying on another person for support. If there's inadequate upper limb strength or poorly fitted crutches, the patient bears weight at the axilla rather than at the hands, and that endangers the neurovascular bundle that passes across the axilla. So if verbal coaching doesn't correct the problem, instruct the patient in another form of ambulation until their strength is adequate, such as platform crutches or a walker. The majority of fractures heal without complications. If there are major complications and death occurs, it's usually as the result of damage to the underlying organs or vascular structures, or complications of the fracture or immobility. And the complication may be either direct or indirect. Direct complications would include problems with the bone, infection or osteomyelitis, bone union or avascular necrosis. Indirect complications include blood vessels and nerve damage, which would be compartment syndrome, DVT, fat embolism, or traumatic or hypovolemic shock. There is a high incidence of infection in open fractures and soft tissue injuries. Massive or blunt soft tissue injury often has more serious consequences than the fracture. The devitalized and contaminated tissue is a great medium for pathogens. Treatment of infection is costly in terms of extended nursing and medical care, the time it takes for treatment or the loss of patient's income, and osteomyelitis may become a chronic infection and very problematic over time. Open fractures require aggressive surgical debridement. The wound is initially cleansed by pulsating saline lavage in the OR. Gross contaminants are irrigated and mechanically removed. The extent of the soft tissue damage will determine whether the wound will be closed at the time of surgery, or if drainage is necessary, or if skin grafting will be needed. Contused, contaminated, and devitalized tissues such as muscle, subcu fat, skin, and fragments of the bone are surgically excised, which is what they do in debridement. And during the post-op phase, the patient will be given antibiotics IV for 3 to 7 days. Elevated intercompartmental pressure within the confined myofascial compartment compromises neurovascular function of tissues within that space. That defines compartment syndrome. It also causes capillary perfusion to be reduced below the level necessary for tissue viability. And it's classified as acute, chronic, or exertional, or crush syndrome. 38 compartments are located in the upper and lower extremities. Compartment syndrome is most commonly associated with trauma fractures, especially of the long bones, extensive soft tissue damage, and crush injuries. There are two basic types of compartment syndrome. where there's a decrease in the compartment size that resulted from restrictive dressings, splinting, casts, excessive traction, or premature closure of fascia, or increased compartment size um, would be related to bleeding, edema, chemical response to snake bite, or IV infiltration. Depending on the patient's age and body mass index, the expected range of intracompartmental pressure readings is 0 to 10 millimeters of mercury, and readings of greater than 30 indicate compartment syndrome. This is a picture of Volkmann's ischemic contracture of the forearm following acute compartment syndrome secondary to a supracondylar fracture of the humerus, and you can see the incision line of an unsuccessful fasciotomy. Early recognition of compartment syndromes is important. Ischemia can occur within 4 to 12 hours after the onset of compartment syndrome. Regular neurovascular assessments are essential, and it may occur initially or it can be delayed for several days. There are 6 P's characteristic of impending compartment syndrome: paresthesia, pain, pressure, pallor, paralysis, and pulselessness. Urine output needs to be assessed because there's a possibility of muscle damage. Myoglobin released from damaged muscle cells precipitates in a gel-like substance that can cause obstruction to the renal tubules. Large amounts of myoglobin may result in acute tubular necrosis. Common signs of myoglobinuria are dark reddish-brown urine and clinical manifestations associated with acute renal failure. Prompt, accurate diagnosis is essential. The extremity should not be elevated above the heart level, as elevation can raise venous pressure and slow arterial perfusion. Application of cold compresses may result in vasoconstriction and exacerbate compartment syndrome. Be aware that pain unrelieved by drugs or out of proportion to the level of the injury is one of the first indications of impending compartment syndrome. It may be necessary to remove or loosen the bandage or bivalve the cast. Reduction in traction weight may decrease external circumferential pressures, and surgical decompression of the compartment syndrome may be necessary, and that would be a fasciotomy. Veins of the lower extremities and pelvis are highly susceptible to thrombosis formation, and the precipitating factors would include an incorrectly applied cast or traction, local pressure on a vein, and immobility. And VTE, venous thromboembolism, may also occur after total hip or total knee replacement surgery. Venous thrombosis may be aggravated by inactivity of muscles that normally assist in the pumping action of the venous blood. You would instruct your patient to wear compression gradient stockings and move their fingers or toes of the affected extremity against resistance and perform range of motion exercises, and prophylactic anticoagulants may be ordered. Fat embolism is the presence of systemic fat globules from the fracture that are distributed into tissues and organs after a traumatic skeletal injury, and it is a contributory factor in many of the deaths associated with fractures. Fractures most often causing fat embolism are those of the long bones, ribs, tibia, and pelvis. It's known to occur following total joint replacement, spinal fusion, liposuction, crash injuries, and bone marrow transplantation. There are two theories of how fat embolism originates. The mechanical theory is that the fat is released from the marrow of the injured bone or being driven out by an increase in the intramedullary pressure, and it enters the circulation through draining veins that and travels to the pulmonary capillaries where it lodges. Um, and the fat droplets go across the capillary bed to enter the systemic circulation where they then embolize to other organs. The biochemical theory is that catecholamines released at the time of the trauma mobilize free fatty acids from the adipose tissue and causes the loss of chylomicron emulsion stability. Chylomicrons form large fat globules that eventually lodge in the lungs, and the biochemical change sets up an inflammatory response secondary to the destabilization of free fatty acids. In the biochemical theory, there is injury to the lung parenchyma, and the tissues most often affected are lungs, brain, heart, kidneys, and skin. Early recognition of fat embolism is crucial in preventing a potentially lethal course. The initial manifestations occur between 12 and 72 hours after the injury, and fat globules transported to the lungs cause hemorrhagic interstitial pneumonitis. So, hemorrhagic interstitial pneumonitis produces signs and symptoms of acute respiratory distress syndrome, such as pain, chest pain, tachypnea, cyanosis, dyspnea, apprehension, tachycardia, and decreased partial pressure of arterial oxygen, PaO2. The clinical course of fat embolus may be rapid and acute. The patient frequently expresses a feeling of impending doom. In a short time, the skin color changes from pallor to cyanosis, and the patients may become comatose. There are no specific laboratory exams available. Certain diagnostic abnormalities may be present, though, such as fat cells in the blood, urine, or sputum, decreased platelet count and hematocrit levels, or a prolonged prothrombin time. A chest x-ray might reveal areas of pulmonary infiltrate or multiple areas of consolidation, and sometimes this is called whiteout. Treatment is directed at prevention, so careful immobilization of a long bone fracture is probably the most important factor in prevention. Management is essentially symptom-related and supportive. Treatment includes fluid resuscitation to prevent hypovolemic shock, correction of acidosis, and replacement of blood loss. You want to encourage coughing and deep breathing, and the patient should be given oxygen to treat hypoxia. Reposition the patient as little as possible before fracture immobilization or stabilization because of the danger of dislodging more fat globules or droplets into the general circulation, and the use of steroids to prevent or treat fatty embolism is controversial. Here's a case study. It's a 23-year-old male brought to the emergency department following an injury to his right arm during a rugby game. His bone is protruding through his. He's shaking and states his pain is a 10 out of 10. He's diagnosed with a fracture of the radius near the junction with the humerus, and he's sent for a closed reduction. So how do you instruct him in pain management and importance? And what must he be taught prior to discharge? And what should he know about the care of his cast? So first, you want to stress the importance of honesty in expressing his pain level and reassure him that he will be given adequate pain medication to manage his pain. Secondly, you want to teach him proper care of the cast and mobility limitations. And finally, he should know that elevation of the extremity above the level of the heart to promote venous return, and applications of ice to control or prevent edema are used in the initial stages. Discourage pulling any padding out of the cast or scratching or placing foreign objects inside the cast because this predisposes the patient to skin breakdown and infection.